I can't remember who I've said this to, but this presentation is going to be about a half hour. Lindsay's going to talk about bioidentical hormone replacement, and then I'm going to follow up with assessing some of the health risks and benefits of it, as well as going over the functional medicine approach. So anyway, without further ado, we are Lindsay Adams and Tressa Brindle of InHealthRVA. We do functional medicine and integrative primary care medicine. And we are going to be doing these webinars mostly about monthly to help educate people so that they can be empowered to take care of their own health and make better health choices for themselves. So without further ado, I'll hand the slide presentation over to Lindsay. So thank you.
Hi, everyone. Again, my name's Lindsay. I'm the nurse practitioner here at InHealthRVA. Good to see you all tonight. So we will just jump right in. Today, as you're well aware, we're going to be talking about bioidentical hormone replacement therapy. Spacebar. Sorry, technical difficulties.
There we go.
Okay, so today we're going to be talking about what bioidentical hormone replacement therapy is. You're going to see BHRT, the abbreviation used a lot tonight, versus what synthetic hormone replacement therapy is. We're going to be talking about some of the symptoms of low or imbalanced hormones. We're going to be talking about what bioidenticals exactly treat. We're going to talk about how we test and how we treat at InHealthRVA, and then how we improve the safety and the efficacy of the use of BHRT. We'll also be talking about our functional medicine approach to hormones and health and so on and so forth. Is it spacebar?
Down button will be right.
Pressing the down, it's not working.
Once you do one. I'll just stand over here.
Okay. So what is BHRT? Again, bioidentical hormone replacement therapy. It's basically treatment for low or imbalanced hormones. It's hormones that are derived from plants, such as wild yams, that most closely mimic those of the human body. Gotcha. Okay. So what is BHRT? What hormones are we primarily replacing? So estradiol, we think of mainly progesterone, testosterone, DHEA, but there's also bioidenticals such as thyroid hormone. It's called desiccated thyroid. I'm sorry, let me go back. Comes from the thyroid tissue of a pig. And we think about these hormones for both men and women, testosterone, mainly for men, of course. Again, bioidenticals most closely mimic the hormones produced by the body. They're derived from plants, such as wild yams, versus synthetic compounds that are formed from chemicals. Both are made in a lab, both man-made, but of course, one is natural versus chemical. The different forms that we like to use: pills, creams, patches, gels, injections. We do not do pellets here at InHealthRVA. Personally, it's a little invasive. Pellets can sometimes cause these supraphysiological levels of hormones that we don't necessarily want, not always the safest route. They also can cause these peaks and valleys of hormones where you can get a hormone crash when you're due for your next pelleting. We definitely prefer a steady state of hormones. So taking it in pill form, cream form, gel form, something that you take every day so you have a steady, consistent dose. Okay, so why do BHRT? Hormones, as most of you know, control our most basic of bodily functions, a lot of our basic health functions, such as body temperature regulation, immune health, our mood, our energy levels, our libido, our metabolism, our sleep are also so important and regulated by our hormones. So why do BHRT? Our hormones can be diminished or imbalanced for a variety of reasons, some including peri and postmenopause, long-term or acute stressors, chronic disease, chronic illness, surgical interventions such as a total hysterectomy, we definitely want to think about hormone replacement therapy. And then just overall inflammation in the body can cause imbalanced hormones. Some symptoms of lower imbalanced hormones are hot flashes, which I'm sure most of you are aware of, vaginal dryness, pain with intercourse, low libido, poor sleep and insomnia, mood changes such as anxiety and depression, hair thinning, fatigue, heat or cold intolerance, and also weight gain. How we utilize BHRT. So we make sure that we test and that we retest often. We always want to be monitoring our therapy. We do like to perform a Dutch test as a baseline to check our hormone levels. It's basically a dried urine test. It tests for our sex hormones, adrenal hormones, cortisol levels, and then how we metabolize our hormones. So it can also tell us whether or not we're at risk for any reproductive cancers, just a really important test and baseline that we like to use. We can always use blood work or saliva testing. That's definitely not the most preferred or accurate method of testing. So typically, I guess the best option is to do a Dutch test first, and then we can follow up with some blood testing that insurance may or may not cover. Unfortunately, the Dutch test is not covered by insurance, but and then we always want to focus on the root cause approach. That is the basis of functional medicine. We want to identify and treat the causes of low hormones. If it's not menopause, if it's inflammation, if it's diet and lifestyle, gut health, nutrient insufficiencies, toxins, and so on and so forth. These are all things that we want to address and address together. It's usually not one cause or one problem that we're dealing with. So for treatment, we do start low, we go slow, we titrate up. We're trying to manage symptoms here, ensure we complete follow-up testing for safety and efficacy. Again, test. Our goal is to reduce symptoms, especially those vasomotor symptoms for women in menopause, hot flashes, night sweats, sleep disturbances. They can be really difficult to deal with. We want to improve disease risk factors. So bioidenticals have also been studied to improve a lot of disease risk factors, such as heart disease, osteoporosis, dementia, endometrial cancers, and then again, test. So we're avoiding those health risks, such as the increased risk of breast cancer, strokes, blood clots. Those are basically the main health risks that we think about. Now I'm going to turn it over to Tressa. She's going to talk a little bit about the research and about our functional medicine approach.
Thank you so much, Lindsay, for going through all of that. So now I'm going to talk about some of the research around some of the risk factors that people are worried about when doing hormone replacement therapy, and pros and cons, and help you kind of try to figure out what may or may not be worth pursuing. And then I'm going to go over the functional medicine approach. As Lindsay's already said, when we're looking at the risk factors for hormone replacement therapy, it's not going to be just about hormones. So one of the great things about what we get to do in functional medicine is it's not just about, do you do hormones or not do hormones because you have this incidence. We can look at all of the other factors and give you proper guidance and support. So health risks of low hormones. We see really increased risk, of course, of osteoporosis and fractures as your hormones drop in your 60s, 70s, and 80s. Heart disease. This is actually the #1 cause of death in women of all people. But, breast cancer does get a lot of press and is an incredibly serious and terrible epidemic. But heart disease is still the #1 killer of women by far. Dementia, the levels of Alzheimer's and dementia are skyrocketing, and osteoarthritis as well. So all of these things increase after our hormones are dropping as part of the aging process. And we can use hormone replacement therapy as one of the things that we do to try and diminish this risk. And of course, as Lindsay mentioned, we need to get through menopause. If you're having symptoms, it can be life-changing, it can be catastrophic. Not being able to sleep, having complete mood changes. A lot of women kind of don't know who they are throughout menopause. And now we actually have the tools since about the 1960s to be able to help women get through this phase of life. So we also have had a lot of research giving very unclear guidance in some cases on what the health risks are of doing hormone replacement therapy. So a major study in 1991, the Women's Health Initiative study, did a pretty good controlled study of a lot of women looking at possible health risks of hormone replacement therapy. Hormone replacement therapy had come upon us, or come into medical use in the 1960s. It had really, really helped a lot of women get through menopause, but we were seeing other increased incidence of reproductive cancers primarily, and possibly also strokes. And so the Women's Health Initiative sort of scared everybody away, because in this particular controlled population of women over 65 who were no longer in menopause, past menopause, not having any symptoms, they were giving them high dose synthetic hormones, and they saw certain increased risks of health conditions. And so there have been in the past 30 years numerous other studies, both analyzing the faults of this particular, the construction of the Women's Health Initiative, as well as doing other detailed studies looking at women during menopause with different risk factors who are symptomatic, finding much different evidence. So it's still pretty hotly debated. And one of the benefits of being in functional medicine is we get to read a lot of the research and keep up with it, and think about all of the other risk factors. So some of the things that women are concerned about with hormone replacement therapy are, of course, reproductive cancers and breast cancers. And with functional medicine, we get to analyze your family risk, your personal risk. The Dutch test allows us to analyze metabolites of estrogen therapy. The 4-hydroxyestrone is, when high, is the one that is promoting to estrogen sensitive cancers. The ratio of the good 2-hydroxyestrone to the not so good 16-hydroxyestrone, we can analyze that with the Dutch test. And so if we are in a woman who has, maybe a slight risk, and we want to do a really good job, maybe she's not doing well, she really needs some hormone replacement therapy, we can kind of know if we are going to be promoting reproductive cancers that are sensitive to estrogen with this test. And we can diminish that risk both by treating to change those 2-hydroxy, 4-hydroxy, and 16-hydroxyestrone ratios, as well as doing the minimal amount of treatment to get her better. So anyway, so the point is that the Women's Health Initiative study kind of created a lot of scare, and we saw hormone replacement therapy drop very suddenly. And there's been a lot of follow-up analysis that has found more of the variation of appropriate application of hormone replacement therapy at the right time of life and with the right conditions. So some of the things that have been analyzed about the Women's Health Initiative study and a lot of other follow-up studies are these things. The onset of treatment timing is important. So one of the major criticisms of the WHI study is it was done in women over 65, many years past menopause, no longer symptomatic, hot flashes, those sorts of things. And so that is, we found, not a great population to just randomly give higher doses of synthetic hormones to. That does pose certain health risks. The route of delivery is important. Transdermal can reduce the risk of certain breast, uterine, and cardiovascular risk that might be associated with high-dose synthetic hormones. The length of treatment can matter. And this is, a lot of these things are, the research is telling us, health condition specific. Lindsay and I have been digging into a lot of the research, and it's, for this particular condition, you want to be doing it at this time. In another condition, you want to be doing it at this time. So we really need to think about the individual person, what's going on, what their health risks are, and then following all of the variables there. And then again, and I will get up on my bandwagon with my signs all day long, heart disease, dementia, stroke. It's not just about the hormones. There's so many more important things you can be doing to control your risk factors for that. And then with a functional medicine approach, we can help you with that. And then we can sprinkle in the appropriate amount of bioidentical hormone at the right time for the right person, monitor it very, very well. So Lindsay is the person here who prescribes all the bioidentical hormones. I can do some natural chaste tree berry derived ones that are available through supplements over the counter. And so we really have a focus here on plant-derived bioidentical hormones. And that's because the molecule is very much more similar to the human hormone molecule. The synthetic ones have more variation away. And there's not enough research in bioidentical hormone replacement therapy to kind of understand those differences, but there's already studies showing decreased risk of certain disease factors that are associated with synthetic, such as heart disease, breast cancers, and incidence of strokes and emboli. So this was a tricky slide to create. We've been talking a lot about it. Some of the evidence, to be honest, it's condition specific. So one of the difficulties with creating population studies and controlled studies to assess the risk of hormone replacement therapy on women in general is we're all different. Some women are eating a processed food diet and drinking alcohol and smoking. Some women have a very significant family risk factor. Like, how do you control when you're doing studies across such different people? And so it's important to think about the individual person. I've probably said that enough times already. But so research does substantiate the use of bioidentical hormone replacement for women who have symptoms. If you're asymptomatic, you don't have hot flashes, mood disturbances, sleep disturbances, then you aren't a good candidate for hormone replacement therapy. I was listening to this other doctor talk about this, and she likened it to basically, if you're going to school and you need loans, like a woman who's having symptoms needs loans to get through school. She needs some hormone replacement therapy. Some people don't need loans. They came either biologically equipped with enough stuff to get them through menopause. So it's not a one size fits all. Not all women need hormones to get through menopause. And then research also, the strongest evidence for hormone replacement therapy is for osteoporosis, really significant reduced risk of osteoporosis and fractures. Bioidentical, appropriate use, appropriate timing. It is also substantiated for heart disease. And for dementia, there's some little bit different population analysis. This can be a population where there might be justification for use for longer periods later in life. But again, dementia, huge topic. We might have some questions about it. Is multivariate. Many other things are leading to dementia. We're not going to rely on hormone replacement for an 80-year-old to prevent dementia. That's completely inappropriate. But so there's many benefits of hormone replacement therapy, and the studies can be confusing, but one of the main reasons the studies are confusing is they're not taking account the individual variation of lifestyle and risk factors. So when we are working with women who have a higher risk of hormone-related disease conditions like breast and uterine cancer. So first of all, if it's really high, we're not even going to go there. We're going to use other methods to try and control their symptoms and get them through menopause. If you have sisters, aunts, mothers, aunts, I said that, first cousins, then probably not a good idea for you who have breast cancer. But then timing, dose, duration, and the form of hormone replacement matters to be able to reduce your risk if you're in someone who can benefit from hormone replacement therapy, even if you have just a little bit of risk for some of these conditions. Age of starting therapy and duration of treatment is important. So except for maybe some of the dementia stuff, some of the long-term osteoporosis and heart disease, we want to start during menopause. We don't want to wait till you're 65. And then we want to treat for an appropriate amount of time and not until you're 90. And then again, one of the most important things for moderating your risk for all of these health conditions that we're worried about with hormone replacement therapy is a functional medicine approach, taking into account all of the other risk factors. So I'm going to go over that now. Okay. For those of you old enough to remember this movie, it's not about the hormones. It's not just about the hormones, honey. Let's talk about all the other things that we want to be paying attention to in a woman who we might be giving bioidentical hormone replacement therapy to prevent the risk factors for the diseases we're worried about associated with that. So one of the most important things to conceptualize, it's not just about hereditary, it's not just about the environment. What we're inherited with, and this says genes, I'm also a big fan of the topic epigenetics. Epigenetics is how our different genes are turned on and off. We're born with a certain blueprint, and then the rest of our life, that blueprint interacts with our environment to form who we are, and therefore also our risk factors for certain diseases. And so one of the wonderful things that we do in functional medicine that is constantly evolving is we try to understand these multifactorial contributions to your health. So this is because we wanted to do a shorter presentation today and then open it up This is a whole other like 3-hour lecture, I'm sure, in and of itself. But here's some of the main things to pay attention to in reducing your risk factor for all of the reproductive cancers, cardiovascular disease, stroke, dementia, osteoporosis. Even if we weren't even talking about hormone replacement therapy, this is some of the most important stuff you can do. Lifestyle matters. When I first got into this, I loved doing lots of complex functional medicine and tests and analysis. There's nothing that substitutes for lifestyle. We need to eat nutrient-dense food, lots of colorful plants, appropriate clean animal products, avoiding processed foods, sugars, chemicals, flours, anything that was probably invented after about 1950. It's kind of a quick way of thinking about it. We need to get exercise. So a lot of women in general, we hit menopause, whatever we were getting away with for diet and stress and toxins, it's something about that hormones interaction with our immune system. All of a sudden, the world catches up to us. And our weight changes, we're tired like we weren't before. And when they come to me, often women in menopause who want to be looking at the hormones, I gained 15 pounds. What happened? And I will say that from both studying all the research, as well as working with women, you have to eat right, you have to exercise after menopause. All the hormones in the world aren't going to magically turn you into a 25-year-old metabolism. So those things are foundational. Fortunately, those are also the two most important things for reducing your risk for osteoporosis, heart disease, strokes, dementia, everything else. So it's kind of a no-brainer. It's cheap, it's free. You can do it yourself. You don't even have to come see Lindsay or I. Nutrient-dense diet, unprocessed, and movement. So a lot of people, especially people who'd be interested in a functional medicine approach, are doing those things. The next most important thing is sleep. And that can be tricky with hormone replacement with menopause, because you can't sleep anymore. And now I'm telling you, you need to sleep in order to heal your hormones. So sometimes you need the hormone replacement therapy to be able to sleep, but we also want to take into all the other factors disrupting that. And then the very important topic around stress and trauma. There's lots of studies now that substantiate the biological impact of either long-term chronic stress, even just from modern living, or as extreme as abuse or trauma. This can be a major factor in disrupting hormones. And when you're being depleted your whole life from stress or living in fight or flight from an old trauma, you get to menopause, you don't have anything left. And then menopause can get very rough. It promotes inflammation as well. And this is true for men also. The andropause, when we deplete through stress, poor diet, not enough exercise, not good sleep, men too, that andropause can hit pretty hard. So upon that foundation with functional medicine, and if you have any specific questions, we can get into it. We analyze you for nutrients. Are you getting the nutrients you need to do the biochemistry that your body needs to do to metabolize and detox hormones, to compensate for inflammation, to heal the immune system, to feed your brain? We look at metabolic syndrome. Metabolic syndrome is by far one of the biggest cause for heart disease, stroke, and dementia. So, that hormone replacement therapy comes kind of secondary. If you have metabolic syndrome, that's going to severely increase your risk of all of those things. Cellular energy metabolism, a fun, complicated topic. Are your cells able to produce energy for you to feed your hormones in your immune system in your brain? And then a bigger topic around inflammation. If you're inflamed, your hormones are going to be off. They're going to get depleted. They're going to be metabolized down the wrong way. And so we want to be thinking about, if you are inflamed, where it's coming from, and improving that in order to get the best results from bioidentical hormone replacement, and then preventing any of the risks that might be associated with it. So that is the presentation, and I'll open the floor to questions from the few people here. And then if you have any questions in the chat box, Lindsay and I will be answering them. So one question about metabolic syndrome so far. Let me see, I can stop the presentation and hang out with you guys here. Sorry, no, you're good. So metabolic syndrome is insulin resistance. So basically, your cells are no longer responding to insulin signal to tell your cells to take up glucose. So you have too much sugar in your blood. Sugar in your blood is majorly inflammatory. And then what happens is your body tries to pump out more insulin to try to get you to take that sugar into your cells. And then high insulin is major inflammatory. States of inflammation drive disease. High blood sugar, high insulin floating around your blood drives inflammation, drives dementia, heart disease, stroke, of course, weight. Kind of it's the foundation of modern disease, really, because there's so much metabolic syndrome because of our diet and sedentary lifestyle. So are there any other questions from the people here today?
So what is the difference, what the different bioidentical hormones? I missed one. I've seen estradiol, progesterone, and then DHEA. So what is the DHEA? What is that?
Okay, so DHEA is produced after menopause, primarily from women's ovaries. Our ovaries are the ones that produce estrogen and progesterone, and after menopause, our ovaries stop producing that. And DHEA primarily, no, I've got that backwards, I'm sorry. DHEA primarily comes from our adrenal glands, not our ovaries after menopause. DHEA is a precursor hormone. It's a precursor for androgens such as testosterone. It can be a precursor for estrogen. It can be a precursor for the adrenal hormone cortisol. And so with the Dutch test, it looks at all of those things. It looks at the sex hormones, estrogen, progesterone, testosterone, and DHEA, and DHEA's conversion into DHEA sulfate. And then we look at the adrenal, which is a gland that sits on top of your kidneys and secretes cortisol, amongst other things. We look at cortisol production, and cortisol production are circadian. It should increase in the morning, drop off in the afternoon, go down for bedtime. And so some women, when they go into menopause, you will always see the estrogen and progesterone go into menopausal ranges. That's a given, 65-year-old woman, low estrogen, progesterone. But there's age-specific ranges for testosterone, DHEA, and you never want to see the adrenal glands cortisol go down. So, depending on what's going on with you, we run the Dutch test, we can pinpoint which hormones you need. Does that answer it, or is that too much information? Okay.
What is the progesterone? When the doctor gives you progesterone, what is that good for, or maybe for? I've heard that it's good. It helps you sleep. It can fight off certain diseases and things like that. That's what I've heard.
Yeah, I'll let Lindsay take it. I'll say I mainly use it for sleep. Like, so when a woman comes in, we look at whatever their symptoms are. If they're not, for example, sleeping, we look at what's your behavior before bed. Are you setting yourself up to sleep? What's your cortisol? That can affect sleep. What's your stress levels? What's your progesterone is one of the things we look at. So that's one of the main reasons I use it. Do you have any other?
Yeah, progesterone is definitely important for any woman who's taking estradiol. You never want to give a woman estrogen and then not oppose it with progesterone, because that can leave you at increased risk for some of these reproductive cancers. So very important hormone.
Yeah.
Your Dutch test, is that one test or is that a series of tests?
The Dutch test is one test, but it is a collection of urine over a period of 24 hours. So
And then you'd repeat it. So like
if we needed to repeat it, of course, we get that baseline, and then maybe a year or two into treatment is typically when we would maybe want to use it again and see where our patients are at.
or if they're not doing well on what we're doing, we might test sooner to try and pinpoint what's going on.
So the Dutch test establishes the basis.
Yes.
Yeah, I was listening. Oh, sorry.
So the saliva, the spit test, is that kind of like the same as that, but that's not as invasive as the, or?
It's not as accurate. The blood testing and the saliva testing, not as accurate as the dried urine test.
The saliva will look at estrogen and progesterone and cortisol metabolites, but it doesn't tell you how estrogens or progesterone or testosterone or DHEA are metabolized, or the cortisol, the saliva cortisol only looks at free cortisol. The Dutch test looks at total cortisol and compares it to how much is free. And so that can be a fun thing to look at because, for example, if you have low total but high free cortisol, that can be, it's not always, but it can be a sign of low thyroid. And then vice versa. I actually had someone just the other day who'd been over medicated on her thyroid medication, and I saw high total cortisol and really low free cortisol. We took her way, way down on her thyroid hormone, and she's like, I actually have more energy now. So it's a really much more complex test that allows us to look at all the metabolites of the hormones, which is really, really helpful for being far more pinpointing everything.
How does this help a person who has already been diagnosed with those diseases such as heart disease, osteoporosis, thyroid disease? How does it help?
So again, patient dependent. When you developed heart disease, when you developed osteoporosis, when maybe a woman went through menopause. For osteoporosis, we typically want to treat within those 10 years of menopause. That's when you will gain the most bone protection, I'll say. For heart disease, I mean, there's no contraindication here. It could improve your disease state, but again, we also want to think about those lifestyle factors.
Yeah, sorry, someone said repeat the question. So the question was, if you already have heart disease, low thyroid, like how does hormone replacement and the Dutch test come into play? And so basically, yeah, we look at all your variables. So if you have heart disease, the answer is never going to be just hormone replacement therapy, even if you need it. It's always still going to be inflammation, diet, exercise, sleep, oxidative stress, cellular energy, nutrients. It's going to be all of those things. So
actually, this could boil down to a lifestyle thing.
there's no replacement for it. So we always coach people on the lifestyle fundamentals, and then we can use functional medicine to really make big gains from there. But there's no pill for sleep. There's no pill that's negate fast food. And let me check some of these questions here. Dutch test 2 years ago. How often should it be tested? That really depends.
Yeah, it really depends on, if you're being treated with hormones currently, of course, whether there's been any follow-up testing, blood tests, saliva tests, if your dose has changed or how often your dosaging has changed for hormone replacement. But yeah, I'd say typically we want to recheck around 2 years at least.
It kind of depends on if your symptoms are being managed. Like Lindsay said, you start low and titrate up. We want to find the lowest possible dose that's effective. So at first, if we're treating you for hormones, we might be repeating that test every few months, even 6 months or so that we can make sure we've got you in the right place, that your symptoms are treated, and that we've taken care of everything we need to do. So yeah, let me see. Can a moderately high blood, saliva, total free testosterone with normal DHT lead to hair loss at the crown in an otherwise healthy menopausal female taking topical estradiol and testosterone? Her estrogen has not gone up with BHRT, but the testosterone has. All other causes of hair loss have been ruled out. Do you want me to, or do you want to?
Yeah, you can.
Okay. So one of the wonderful things about, I'm not being paid by Dutch test. I love this test. So estrogen can be converted into testosterone. Testosterone can be converted into estrogen. With the Dutch test, we can check that. Actually, in male hormone replacement therapy, this happens a lot. They'll be being treated with testosterone and it gets funneled over to estrogen, and their testosterone's barely moving the marker. And we have to use things to stop the testosterone from becoming estrogen. So causes of hair loss, I mean, specifically crown, that's kind of male pattern. So I would say we really want to check her estrogen and testosterone and seeing how it's being metabolized. If it's being metabolized into DHEA, more into testosterone, you could be using aromatase blockers, either plant-based natural ones like saw palmetto, nettles, pygeum. They might use spironolactone in a clinic. I've never used that, but yeah, if your estrogen's not gone up with BioIdentical and you're using estrogen testosterone, from what tiny bit that you told me, it sounds like it's all going down into male androgens rather than into the estrogen. But then with hair loss in general, you always still want to be thinking about inflammation and nutrients too. So inflammation, the two things that will drive estrogen into becoming testosterone in women are inflammation and genetics. So if this person is eating a processed diet, has gut microbiome dysbiosis, toxins, other stress, stress will majorly take estrogen down into the male testosterone androgens. That can be a reason why that's happening. So, okay, anything?
So what bioidentical hormones are relevant to maintaining, improving cognitive health, memory loss issues? How does someone determine dosing or hormone combinations? So when we think of cognitive health, that is mainly estrogen and progesterone we're thinking about. Dosing, again, patient dependent, what our tests are showing, what the Dutch test is showing, where we're at initially. Again, we start low, we go slow. Second question, is hormone supplementation beneficial throughout postmenopausal years, basically for the lifetime after menopause onset? So this is, unfortunately, there's not a whole lot of clear research on this about how long someone should be on hormone replacement therapy for some of these health benefits. But we have seen patients on it for long periods of time without any, side effects, any risk factors, stroke, clots. But typically we think about 10 years.
The functional medicine part I would say to that is for dementia. Lindsay spoke about the hormones, but dementia, if you're interested in it, there's a great book by Dr. Dale Bredesen, Bredes, I believe E-N. And he was an Alzheimer's dementia researcher who accidentally became a functional medicine practitioner because dementia, Alzheimer's are absolutely multifactorial. So hormones is one part of a very big ocean of things that need to be considered if you have a high risk factor for dementia or Alzheimer's. Sleep, diet, stress, inflammation, toxins, infections. Those are some of the other main areas. Oxidative stress that need to be thought about for dementia and Alzheimer's. If you have a high risk of dementia and Alzheimer's, don't rely on just hormone replacement therapy. And then, yeah, throughout menopause, as Lindsay said, usually in a functional medicine approach, we're treating with, she's a prescriber. I don't have the benefit of prescribing. I use plant-based hormones, and I literally use a drop or 10 drops. So I use like these micro doses along with everything else. And I haven't had the benefit of treating anyone for 20 years, but I would imagine I would be tapering off when we're able to. I mean, so I have patients in their 70s or 80s, and there's not really a need to be giving them hormones at that point. So yeah. Thanks. Okay. I think that's all the questions. Anybody else? Yeah.
Yeah, I have two questions. One was, once the female passes through menopause, does everything kind of level out and the symptoms start to go away, and therefore it becomes more appropriate to start taking them off? Like, do the hot flashes and all this type of stuff level out on their own, and then you don't need the hormone replacement much?
I would say in most patients that I've seen and treated, they do seem to kind of plateau and level out at a certain point. So yeah, again, we're treating symptoms. We're also thinking about improving disease risk factors. Patient dependent, but from what I've seen, yes, it typically at some point will level out.
With the treatment from you guys, it should level out, is that what you're saying, if you did treatment?
Yes, we should definitely get some symptom relief, if not complete symptom relief at a certain point, between titrating our doses, hopefully. But also a woman coming off of hormone replacement therapy or being weaned off may, if she's been through menopause for some years, may not have those symptoms anymore. So all things we take into consideration.
Yeah, I'd like to point out that menopause isn't a disease state in of itself. It's a natural progression. And so we want to think about the many reasons and what's going on in people, but I don't usually see women in their 60s, 70s, 80s with proper treatment being weaned off and having any problems whatsoever. So we use it mainly for the transitional period.
I guess my other question was, if you've got like chronic inflammation or chronic or an autoimmune issue, can you
can you go into any type of hormone replacement, or does that kind of need to be managed? The chronic inflammation and stuff, like, does that need to be managed first before you go into some type of hormone replacement, or can the hormone replacement help the chronic inflammation, or how to just from that interaction?
So the question is,
So I
with,
can be more specific, more specific.
yeah,
I have Lyme, Bartonella, like, and about 3 other different ones.
mhm.
And so I'm also 46. So the interaction, kind of like the intersection of those two things are coming upon. And I'm just wondering, like, can they be managed in parallel, or do they need to kind of like one and then the other?
Yeah, absolutely. So the question was, we have a patient here dealing with an autoimmune disease, some inflammation, wondering about being treated with hormones at the same time. Do we want to treat the inflammation first, or can we treat simultaneously? We can absolutely treat simultaneously. Hormones are actually being researched right now in the pain management field to kind of help with those who are struggling with maybe autoimmune conditions or chronic illness, chronic pain syndrome. So it definitely helps fight inflammation. We would work on it congruently together.
Yeah. I often call hormones collateral damage. So hormones get a lot of press, but hormones are collateral damage from inflammation, from long-term stress, whether that's inflammatory stress, cognitive stress, social stress, that will dysregulate hormones. And so absolutely, I would say it's in conjunction at the same time in order to help allow that person to have a life and to feel better and to function. But I don't like to see my chronic fatigue or inflamed or autoimmune people just jacked up on hormones. So that's kind of something you can sometimes see in other parts of not properly done functional medicine or bioidentical, where they're just like on too much thyroid or, on tons of testosterone. And yeah, so we just want to make sure we are addressing the reasons why, whether in menopause or perimenopause or otherwise, that their hormones are being dysregulated. So yeah.
Question here, is there any relationship between long-term UTIs and low hormones? So I think something that menopausal women will struggle with is vaginal atrophy. And this can, of course, cause symptoms of feeling as if you have a UTI, the burning when you urinate, the frequency. And so I think a lot of menopausal women think that they constantly have UTIs, and that may necessarily not be the case. It may just be that you need some extra hormone support. You may need a suppository. Definitely patient dependent, but hopefully that answered that question.
I've also, actually, I learned about this a bunch of years ago. Maybe I shouldn't say, I learned about this with my dog. When the estrogen is really important for the moisture of all of the sphincters down there. And so as the urethral sphincter gets more dry, that can lead actually towards 2 more UTIs, and also to not being able to control urinary stream as much. So local and topical estrogen can be really helpful for that. Yeah. Is there anything else? So we'll just hang out. We've got 9 more minutes. If anybody else, any questions here, and we'll hang out if anybody else in the Zoom meeting has any other questions. But so I'll just reiterate here at InHealthRVA, we do functional medicine, root cause medicine. Lindsay here is a nurse practitioner specializing in functional medicine and has another specialty in bioidentical hormone replacement therapy. My background's in Chinese medicine and in neuroendocrine immunology research. So I got into this from just trying to understand every little bit of the body everywhere, how hormones interact with the nervous system, interact with the immune system. It's all one system. And it's a really good intro into modern disease and human health and disease. So if you have any questions or issues for that you need addressed, you can always email us at info@InHealthRVA. Give us a call at 804-288-1111. We're here to help. So thanks.